Now, if we look at a summary of results from PORTEC 1 and PORTEC 2, we can see that with radiation, either external beam radiation or vaginal cuff brachytherapy, that we can reduce the risk of a vaginal cuff recurrence to about 1 to 2% from maybe about 11 to 12%. And the risk of 5-year pelvic relapse is about 3 to 4% of patients are observed, and we can reduce that down to about less than 1 to 2% with external beam radiation. So that difference is pretty modest, and so I think we could conclude that vaginal brachytherapy for these patients is sufficient, and even some may say that the risk of vaginal relapse is quite low in the observation arm with 10%, and that these patients could be observed as well. And so in general, we at the University of Pennsylvania do recommend vaginal cuff, or have in general treated these patients with vaginal cuff brachytherapy in the adjuvant setting if they are unstaged. But it is a discussion between the GYN oncologist, the radiation oncologist, as well as the patient about these concerns. Now, what about high intermediate risk patients? Do we give them vaginal cuff brachytherapy, pelvic radiation, and do we combine this with chemotherapy? So in this older Norwegian randomized study, patients with clinical stage 1 uterine cancer underwent TAHBSO without a lymph node dissection and all received vaginal cuff brachytherapy, and then were randomized to either no further adjuvant therapy or pelvic radiation. Now, the biggest conclusion from this study came from the observation that patients with high-grade disease and deeply invasive disease had very high rates of recurrence, whether they received radiation or not. You can see 18% in the patients that received radiation died from their disease. And so in PORTEC 1, these patients, as I mentioned earlier, were excluded from the study, but they did, in a separate analysis, look at these patients with deeply invasive high-grade disease and compared their outcomes, their relapse outcomes, to patients that had lower grade disease and less invasive disease. And you can see that even with radiation, these patients did significantly worse. So what else can we do for these patients? Well, one consideration is chemotherapy, and I don't want to go too much into detail about chemotherapy, as I know there's a talk right after this on chemotherapy in the adjuvant setting. But GOG 34 was a randomized study of radiation plus or minus adriamycin chemotherapy and showed no benefit. The Japanese GOG group conducted a phase 3 randomized study as well that did include patients with uterine cancer, but also included patients with much higher risk disease up to stage 3C. And they were randomized to pelvic radiation or chemotherapy consisting of cisplatin, adriamycin, and cyclophosphamide. And they showed that there was no difference in progression-free survival overall, but they did try to identify a group of patients that might benefit from one therapy versus the other. And they did identify a high intermediate risk group of patients, those with stage 1C disease who were over 70 or had high-grade disease, or stage 2 or 3A patients with positive cytology and deeply invasive disease. And what they found was those patients had a significant progression-free survival benefit with chemotherapy.